Thank you very much, Joel, and thank you to the IPC for inviting me. Can you see my slides okay?
See them perfectly.
So here are my disclosures. So in thinking about what registries have taught us about stratification, I want to briefly consider endotypes or subgroups, then discuss the strengths and potential weaknesses of registry data, and then think a little bit about the kinds of data that allow us to stratify, which are predominantly two kinds. One, the demographic and clinical factors that clearly are collected as part of a registry. And secondly, biomarkers, which are increasingly developed with samples being collected associated with these registries. Just go back. So the concept of stratification, I think, will be familiar to this audience. But in brief, the concept is that within a population such as stable plaque psoriasis, there are hidden subgroups that you don't quite see. They may be associated with particular clinical phenotypes, but either by mechanisms of stratification and biomarker discovery, you can identify these signatures and then associate them with things like clinical response and non-response. But I want to make it clear from the beginning that many of these things are not binary, and that defining response can be quite tricky, as can be ascertaining whether an adverse event relates to a particular drug that's been used in the context of psoriasis. So if we think about the value of registries, clearly they represent real-life clinical practice and are therefore distinct from clinical trials. Importantly, clinical trials in general are not powered to detect rare but important side effects, nor are they stratified for biomarker discovery or replication. One of the most important factors there is that the patients who enter trials are often different to those in real-life clinical practice, and a number of studies have highlighted this, showing that about 30% of real-life patients would not be eligible for clinical trials. And clearly, one of the important things about registries, it allows for longer-term outcomes to be determined, such as adverse events, as well as long-term sustained efficacy, which we're all after for our patients. There are, though, some potential weaknesses of registry data. Clearly, these patients are not randomized, and that may lead to selection bias and confounding. And that's illustrated by a comorbidity such as psoriatic arthritis that may be a factor in how a physician selects which therapy or biologic to use, and it may also affect the decision to switch to a biologic depending on the response of both the skin and the joints. Now, this can be compensated for to some extent by a statistical mechanism called propensity scoring, which, if you like, is a weighting and allows you to essentially treat registry data like a randomized controlled trial. Missing data is important because patients don't attend at the same frequency or regularity that they would in a clinical trial. And as I've already alluded to, the measurement of outcomes such as efficacy and effectiveness is quite tricky. And we may use surrogate markers, as I'll illustrate, with drug survival. And there's also issues about PASI measurement in a clinical setting and how this changes over time. And even in large registries, there may be not sufficient power to detect very rare events, and then you have to put them all together. So this systematic review back in 2016 looked at 56 articles about registries, and I focused here on the articles that it was identified to do with predictors of treatment response. And only at that time, there were 6 articles covering 4 registries. One of the first to consider this was a Spanish registry, Biobaloderm, and this focused on more than 1,000 psoriasis patients and specifically looked at whether weight and BMI affected outcome. They looked at discontinuation of therapy, and they found there was a significant association with lack of effectiveness with increasing BMI and also more adverse events. And to put that into a clinical context, if you have a 5-unit increase in BMI, then there's a 12% risk of lack of effectiveness and a 17% risk of adverse events. So these are really important real effects that are affecting outcomes of clinical treatment. They found that this was independent of therapy. In other words, it was ubiquitous of both systemics, conventional systemics, and biologics. For the rest of the talk, I'm going to focus on some UK work that I've been involved in, which relates to bad beer and also sort and B-stop. So bad beer is one of the largest collections of registry data with more than 20,000 registrations, almost 14,000 on biologics and almost 6,000 on a control cohort of conventional systemic. So it's a very powerful cohort. Let's get on the slides. And this study shows here that when we looked in total at some other factors that may be relevant in terms of clinical outcome, we also found that weight was an important factor. You can see quite a big risk ratio here. And other important elements occurred, such as white ethnicity, as well as the presence of psoriasis on palms and soles, together with some others that there's not time to discover. But taken overall, the actual contribution to the risk of outcome was only about 10%. And so this really underscored the need for biomarkers to accompany these clinical factors and to combine, and that will give us a greater degree of outcome. But before I get to biomarkers, I want to just illustrate that persistence is dependent on drug. And this isn't surprising to us in clinical practice, but very clearly you can see that those patients on adalimumab have a much less drug survival compared to those on secukinumab and ustekinumab. And importantly, this is affected by whether patients are biologically naive or not. So if you compare the red and the orange dotted line, you can see they're very close. So for adalimumab, it doesn't appear to make much difference. On the other hand, for secukinumab in blue and dotted blue, you can see there's quite a wide separation. So for secukinumab, it does matter, and you do less well if you get secukinumab after another biologic. You're better off having secukinumab when you're biologically naive. The other important application is machine learning, which has been increasingly applied to these data sets. And here we're looking at the trajectory of response, not just an outcome at a particular time point. And it's important to compare this graph with the individual classes that emanate from the analysis. And the machine learning identified that 4 was the optimal class number. And then you can see that there were differences. This data is pretty noisy. You can see that some of the lines are all over the place. But overall, these patterns are consistent and statistically relevant. So class 1 in general does less well, gradually improving but slowly. Classes 3 and 4 improve quite a lot more. But you'll notice that classes 2 and 4 improve and then get worse. So very distinct patterns of response that resonate again with us in clinical practice. And importantly, these classes also associated with other outcome measures, such as PASI 75 at 6 months. And they also associated with some of the clinical factors that we've already found to be predictive, such as BMI and the involvement of palms and soles, as well as in one group an association with HLA-CW6. And these classes, as well as having those outcomes, also show differences in survival. So perhaps not surprisingly, given the low response rate of class 1, they were the class that switched the quickest. If we go on now to biomarkers, a very useful systematic review has just been published, covering 22 articles in psoriasis and 22 with psoriatic arthritis. 10 studies have looked at the association of HLA, and 3 have focused on HLA-CW6, which we'll come to. Importantly, in psoriatic arthritis, high levels of baseline CRP associate with a better clinical response. And that again is for both systemics and biologics. And note this covers 13 registries and more than 8,000 patients. In general, though, this review concluded that most studies are underpowered, and in general, there's a lack of replication. HLA-CW6, as you know, is the most common genotype associated with psoriasis, and it's associated with a particular clinical phenotype that we recognize: younger age, more severe disease. And in a study led by Nick Dan that combined sort and bad beer, studying more than 13,000 patients, here we found a difference in the response depending on the drug. So you can see there's a separation of these lines here measuring PASI 90 or a number of different time points, showing that patients who are HLA-CW negative in general do better with adalimumab than with ustekinumab. And this was further exemplified by different PASI outcomes all finding the same, and the difference got wider when we looked at patients with psoriatic arthritis. So together then, I hope to have illustrated that we've now got clear evidence that there are particular clinical phenotypes that you can look at in the clinic that will act as a measurement of how a patient is going to respond in general. And if we start to combine that with biomarkers and particularly genotypes, then we can predict at an individual response level to a drug. And I think the next phase, which we're probably going to hear about in the next talks, is the power will be to combine these in an integrative analysis relying on modern AI technology. And this work that I presented represents a great collaborative effort, both in the UK and wider. And I'd like to thank all my colleagues as well as the funding bodies for their contribution to this work. Thank you.
Okay, so the webinar can begin officially because I was talking while I was on mute. So, all right. So Nick, that was really a tour de force on a complicated topic. I think it's important for our listeners to appreciate that registries are a somewhat new phenomenon in the field of psoriasis research. They really didn't start until sort of the early 2000s and sort of beyond then. And at that time, we had almost no longitudinal data on people with psoriasis. Most of it was based on survey data, things of that nature. And that really created huge delays in our understanding of natural history of disease, comorbidities, things of that nature. So it's really exciting to see this work emerge. I wonder if you could maybe speculate a little bit about what do you think is going on with patients who don't respond as well or don't have as good persistence when they've already been biologic experienced. Do you think that's just a matter of that some patients are just harder to treat and will cycle more through drugs? Or is it possible that if we use the wrong mechanism initially, that may make the patient's sort of pharmacodynamics change and make it harder to treat them going forward? What do you think's at play here?
Great questions. And I think those are the kind of things we do need to address. I would think the only thing we really know about is the formation of anti-drug antibodies. So for adalimumab, it's clear that that has a profound effect. And indeed work that we've done in this field, led by Catherine Smith, has shown that if you measure drug levels early on, it's predictive of response. And we're starting to use this in the clinic now to drug dose escalate depending on the levels and whether or not patients have got antibodies. So if you've got a propensity to get antibodies, even to the less, the drugs that are less allergenic, if you like, I still think that potentially produces a risk. And we also know that duration of psoriasis is important. So, there's an increasing interest in targeting people early before they've got this chronic memory that's ingrained in both the immune and the innate systems that makes them more tricky to treat. So I don't think, I don't know if others have got any data to support it, but I think all those suggestions you made need to be formally tested.
I think certainly the idea you're bringing about pharmacokinetics is an important one. And it may be that a lot of patients are losing response, not because of pharmacodynamics, but because their drug levels aren't high enough to get what they need. All right, this is a great discussion. We have good questions coming in through the chat. But why don't we move on to our next talk?